is key. Data analysis is crucial. That is the only way that we could really effectively end this pandemic.
Okay. Well, thanks, Dr. Celi, for joining us. This is one of our first Kiwi Leadership Network interviews. We're doing a special on COVID-19 because this is really affecting everybody in the United States. So the Kiwi Leadership Network, we're a 501c3 nonprofit, really trying to help Kiwis succeed in New Zealand, in the United States, sorry. And Leo, who's American, but has lived a lot of his time in New Zealand as an internist in Dunedin, where we first met as physicians. He taught me, and I also worked with him in Boston. So Leo is an internist and an intensivist and infectious disease specialist. He's an associate professor at Harvard Medical School. He's the research director at the MIT Laboratory for Computer Physiology. And he offers really a unique perspective. He also has qualifications in a Master's of Public Health, MSc from MIT, and has really been doing a lot of research in artificial intelligence and also medicine. He's also a practicing clinician. He is an attending physician at Beth Israel Deaconess. So, Leo, thanks for joining us here on this call. How are you doing?
I'm good. Thanks for having me, Xaviour. It's good to see you.
Yeah, thanks, Les. So you're based in Boston. Can you just tell us briefly a little bit about your background and when you first found out about COVID-19?
Sure. So I work in the medical intensive care unit of Beth Israel Deaconess Medical Center. Before the pandemic, we have about 70 to 75 ICU beds. At present, we have expanded to 130 ICU beds, and plans are underway to increase further to 200 ICU beds in case we need it, because the number of cases continue to increase over the past week.
So how do you do that? Like, I take it where you are, you can't just add beds and rooms. How has this been coordinated?
So we started surge planning way back in January. At that time, we thought that we are gonna go through this planning, but at the back of our minds, we were thinking, oh, it's never gonna be this as bad here in the United States as compared to what we have seen in China and Italy. But of course, that didn't happen. We're here in the middle of the storm. As I said, we have doubled our ICU capacity. What that means is that all hands are on deck. In the period before the pandemic, we would have, from our division, we would have 3 attending physicians during daytime and 1 at night. Now we have about 8 attending physicians during daytime and around 3 to 4 at night. And the patients that we're seeing are crazy sick. Normally, when I work in the intensive care unit, there will be, out of 10 patients, there will be 2 or 3 sick patients, and the rest are the usual bread and butter. They just need to stay in the ICU for 1 to 2 days and then turn around very quickly. But this time, I've never seen such a high acuity of patients where a lot of them require interventions almost every hour. We're having difficulty in terms of oxygenating them. A lot of them would develop other organ failures. So it's really testing your ability to manage a patient with severity of illness.
And what sort of patients are you seeing? What are their ages? What is their demographics?
It's very different from the reports that came out of China and Italy. The initial reports describe a largely older population with a lot of chronic medical conditions. As we have seen in New York, as we are seeing here in Boston, the median age is not in the 70s or 75. We're seeing the median age around 50 to 60. In the intensive care unit where I worked last week, we had a patient who was 38 years old, 41 years old. We've had several patients who were in their 20s. A lot of them were previously healthy, and not all of them are obese. We've seen from the reports that obesity is a risk factor, but we've seen patients with a normal body mass index. So it's suggesting that the virus is undergoing some mutations. And we've seen a report where indeed they have showed nicely that there has been mutations when you compare the virus that was first isolated in China as it traveled the world. And this could be the explanation why we're seeing a different phenotype of the virus and we're seeing a different patient demographic here in the United States.
Are you seeing with some of those patients a lot of comorbidities with like hypertension, high blood pressure, or existing kidney problems that they're more predisposed?
It's funny because, as I said, the patients we're seeing in our ICU are definitely younger. But what we're missing here are patients who are dying in the nursing homes. So we're not seeing them in our ICU because they died before they could come to us. And I think for that reason, the population that we're seeing is kind of skewed because we have excluded the people who are older, who have more comorbidities, because they don't even have time to come to our ICUs. And we've heard this ridiculous number of people dying at home, dying in nursing homes before they could come to the hospital, before we could come to their aid and really support them during their illness.
And what are you seeing in Boston? Are the nursing homes locked down, or how are they coping with this? Are many of them getting a lot of infections through the nursing homes?
We're not seeing much details. I mean, all you really hear about are some news articles, but there has not been a more granular information. At this point, it would be great if we could really see the stats coming out of nursing homes, how many are infected. There has to be, I'm hoping, and I really do hope that there is mass testing happening in the nursing homes so that you could isolate those who are infected versus those who are not infected. There has to be nursing homes that are taking care of only infected residents, and there has to be clean nursing homes. So that's how we manage our patients in the hospital. We have clean ICUs and we have dirty ICUs. For the dirty ICUs, those are patients where all of them have COVID-19 infections, and the clean ones are the ones where they tested negative. And that should be the case for the nursing homes as well. So if you're a healthcare worker working in a clean nursing home, you should be tested every day so that you don't end up passing the infection. As we've heard from several reports coming from China, coming from the UK, a lot of patients who get infected are asymptomatic. They do not know whether they are capable of infecting other people. So it makes sense that if you are working in an environment where there are a lot of people who are vulnerable, that you should get tested routinely because those could be hotspots for transmission. And the same thing in hospitals. Everyone has been really advocating for repeated testing of healthcare workers because what you don't want is for more transmission to happen in the hospital. Just because that's a very hot zone, a lot of the infected patients are there, so there's definitely a higher proportion of or higher probability of transmission. And this is why it's very important, and it's been repeatedly emphasized. Mass testing is going to be a crucial part of being able to contain this pandemic.
What sort of testing are you doing at the moment? So just can you explain to the audience the different types of testing? So is it the nasal PCR that you are doing? And then are we doing serum antibody testing through the blood at the moment?
So PCR is the test of choice in terms of determining whether they're infected or not. The turnaround time now is much faster compared to the early days when it took us 5 days to find out whether a patient is positive or negative. And as you can imagine, we wasted so much PPE. If the turnaround time for the test takes 5 days, of course, while waiting for the test, you have to treat them as positive. And it turns out that a large fraction of them actually turned out to be negative, and all the PPEs used were unnecessary. But PCR, the version that we have now has a relatively very rapid turnaround. If it's positive, we find out within a few hours. And if it's negative, we have to repeat the test again 24 hours later before we could definitely say that this is negative. So there are false negatives that you would like to adjust for or you would like to account for. And that's the reason why we need 2 negatives 24 hours apart before we declare someone as negative and before we release them from isolation. The serologic test is not being done widely. We've heard reports about the suboptimal accuracy of the serologic test. There are going to be false positives and false negatives. And we also don't know whether being positive for IgG, which is typically the antibody that we see when someone has recovered, whether that is going to be truly protective. So there are more questions than answers right now. And this is the reason why we have not done scaling of antibody testing at this point. We're doing them, but primarily for research purposes so that we will know more about what to make of a positive and negative test with the antibody testing.
And so is there any role for IgM testing? So that's the first antibody I understand that is raised, and you might have that window period where that might be positive when the PCR is negative. Is that correct?
So we're not doing that right now. We're just relying on PCR for testing. As I said, we don't know the true positivity rate, the false positivity rate of IgM and IgG, what a ratio means in terms of where they are with their disease process. We need more research. We need to get more data. We need to understand what's going on.
How are you?
Go ahead.
How are you finding? You mentioned about the PPE and the use of and things. How are you doing in terms of stockpiles, in terms of your PPE, the testing, the reagents for your testing, even the ventilators, the clinical things? How is Boston doing?
So we're okay. We're fine when it comes to the ventilators. As I said, as our numbers went up, the hospitals were prepared. We were not caught off guard compared to New York, where they really saw an exponential rise in the number of cases over such a short period of time. In Boston, the rise was definitely less steep. And for that reason, we were able to mobilize a workforce. We were able to determine and expand the number of ventilators. At present, we are using some anesthesia ventilators. So there are 2 different types of ventilators. There's the regular one that we use in the intensive care unit. And there's also one that it is used in the operating theaters. Those ventilators are capable of delivering anesthetic gases and also being able to maintain patients for a short period of time. And these patients are typically not that sick. So for less sick patients, we have a unit that is using anesthesia ventilators, but they are not really built for patients in the intensive care unit. So we've had some issues, and they required a lot of troubleshooting because these ventilators are not meant to be used for more than a few hours at a time.
How are you triaging patients? I mean, you mentioned just now, like, you've really restructured the hospital in terms of the flow with types of patients. How are you, like, you get a patient, how are you finding, like, whether they come in, whether they go home, whether they go to the medical ward, or triaging which part of the hospital they go to?
So it's funny, at this point here in Boston, we have actually seen a lower number of patients presenting to the emergency department compared to baseline. So what we've seen is that people are scared to come to the hospitals. So we're seeing, surprisingly, we're seeing less of the case of the patients that we normally see in the intensive care unit. We're not seeing the gastrointestinal bleeding. We're not seeing as much of the diabetic ketoacidosis. We're not seeing complications from end-stage renal disease. And I think the reasons for that would be complicated, and we would really be interested in analyzing the data that we're collecting now during this pandemic to understand better. But in terms of triaging patients, the reason for admitting them to the intensive care unit is the same reason that we had prior to the pandemic. And you're mainly looking at 3 organs that will qualify them for admission to the intensive care unit. Are they having problems with their lungs? Are they requiring oxygen that cannot be delivered safely, an amount of oxygen that cannot be delivered safely in the wards and would require closer monitoring? So these are patients who are really requiring either high flow nasal cannula or non-invasive ventilation, or the worst one is mechanical ventilation. Are they having problems with their blood pressure? Are they requiring medications to artificially elevate their blood pressure, because their blood pressure is the main determinant of blood flow to the other organs? So that's another reason to get into the intensive care unit. And then the third reason is their brain function. Are they too sleepy, or are they too confused so that it would be unsafe for them to come to the floor? So in terms of criteria for triaging of who goes to the intensive care unit, nothing much has changed. We're still having the same criteria for them to be considered sick enough to come to the intensive care unit.
Sure. You mentioned about New York. Why do you think they've been hit so much more than other cities? Is it because of the dense population? Is it because of the metro system? Is it, we've also seen this disease, unfortunately, is targeting more lower socioeconomic people, those of different ethnicities. Do you have any thoughts or comments?
So I think it's all of the above. There's definitely some evidence that there are disparities in terms of who gets infected and who dies from this infection. We're seeing some evidence that Blacks and Hispanics are disproportionately affected by the pandemic. We've seen that in Chicago. We've seen that in New York. And there are various reasons why we're seeing these disparities. One of them is the size of the household. So in New York, they're more likely to be crammed in a much smaller space. So there will be more members of a family living in the same unit. And as we've learned from China, the vast majority of transmission actually happens at home. So we think that that could be a reason why we've seen such a surge in the number of cases in New York. And then also the type of jobs that people work in would also be a determinant of their the probability that they get infected. If they are people facing when it comes to their job, um, are are they working in restaurants? Are they working in grocery stores? Are they working in hospital facilities? Then they are more at risk of catching the infection.
And you also talked about China and Italy. What have you seen from their data? Like, have you any comments about how they're progressing? I mean, it seems that China had a big lockdown and they're sort of getting things better, but Italy still has quite a high toll. And also the region of Italy is not every area, like the Lombardy region, for example, has seen quite a large incidence of things. Have you any comments about what they're seeing? And also you talked a little bit about the types of people that were getting infected.
Yes, so we're working with data coming from China. We're about to start our analysis of data coming from ICUs in Italy. The data from China comes from the hospitals that were built within 10 days. And it's very impressive. They built a 3,000 bed hospital within 10 days and hired doctors, nurses, and other healthcare professionals from around China who have never worked with each other to start forming teams to care for these people. And what we found, and I was very impressed in that they were able to improve outcomes over time. We found that the length of stay of the patients, even a few weeks after after the opening of the hospital, was significantly shortened. And I think it's a testament that they were able to work together, even though these are strangers who have never worked with each other before, but somehow they managed to pull in and really concentrate on providing the best care. So we're writing this up. As I said, it's very impressive that in a matter of a few weeks, they were able to improve patient outcomes. Even though these are people who come from all around the country to work in this newly built hospitals, 3,000 beds to care for, the entire hospital is for COVID-19 patients.
It's very impressive. What, in terms of learning from other countries, what do you think the best method for that is? I mean, you've given quite a good example with China. Is there a way is it through the literature? Is it through reports or through collaborations?
I think it's through data. We keep harping that the best way to contain, to mitigate, to end this pandemic is to collect and analyze data as much and really learn about the behavior of this virus. And we've seen that with the countries who have shown a better record in terms of containing the pandemic. Mass testing, I mentioned earlier, is one of the key ingredients. And the other one is collecting the data and analyzing the data real time, figuring out where are the hotspots of transmission, and figuring out also what the impact is of policies such as social distancing. As you know, there are a lot of ongoing debates about social distancing and the impact on the economy. And clearly this is something that we cannot maintain long term, and people are eager to restart and release people from the lockdown, but we cannot do that unless we are collecting data. So the only way that you could say that it's safe for people to reopen their businesses you can only do that if you're on top of things. Like as soon as there is any evidence that the number of cases are beginning to rise again, then you have to go back to a lockdown. But there's no way for us to know this unless we are able to collect the data, uh, do repeated testing, especially for people who are working in businesses where you could have gathering of a large number of people. So as I said, data is key. Data analysis is crucial. That is the only way that we could really effectively end this pandemic. And we have that advantage over the virus. I think it was Yuval Harari who said that the viruses cannot talk to each other and figure out how can we infect humans better, more efficiently. But as humans, we can compare notes, we can learn from each other. And that is really our best defense against the virus.
Have you been following things? You used to work in New Zealand. Have you been following things back in New Zealand?
Yes, so I think everyone is aware of what a good leadership is in terms of in crisis situations like this. So I think the whole world is aware of how small the numbers are when it comes to the cases and deaths from COVID-19. We are hoping to emulate what you have done there, and the whole world is really trying to learn and implement some of the lessons learned from New Zealand. So kudos to New Zealand, and we hope that we could adopt some of the best practices that you have implemented there.
So New Zealand, I think we're in week 4, week 5 of lockdown, and we're about to go down to a level 3. Is there anything that you would do if you were running, say, the Ministry of Health in terms, you've talked about testing. I mean, we have only just started to see random testing here, and I don't know actually how much we're actually doing. What would you suggest that we would do? And I think we were talking before the call, you know, that we need not to be complacent and that things could get worse here. I mean, what are your thoughts on that? And then also with New Zealand as an island in terms of, do we need to lock the border down or do mass testing? What would your thoughts be?
So, I mean, it's the same advice really, is to be on top of the data, be on top of the data analysis. I think this is a good opportunity to promote crowdsourcing of knowledge generation. So that has been the mantra of our group. We need to get the data into the hands of as many brilliant minds as possible. There are ways to protect privacy, but the more perspective that comes into the data analysis, the better it is. If you only have a few people looking at the data, performing the analysis, I think you're less likely to really leverage the knowledge that is contained in that data. But if you have social scientists, machine learning experts, the public health practitioners, the clinicians, the doctors, the nurses, pharmacists, looking at the data that's being collected near real time, then I think you're more likely to really come up with the best way to move forward.
Sure. So you've got an interesting role where you're a clinician, also you're a data scientist. Can you just talk about research in this current time? Probably first, let's talk about some of the treatments and then the wider use of data and the population-based things. So you mentioned when we've talked in the past about some of the treatments that are coming in. How difficult is it to analyze different treatments? We've seen hydroxychloroquine being suggested, but maybe it's not affected. How do we analyze medications in such a crisis situation?
So once again, I think the value of having so many pairs of eyes looking at the data, I think we're less likely to come up with the wrong conclusions. So what happened with the hydroxychloroquine is that there were these two small studies that came from France, from the same team in France. That data was not really made open access. They were the only ones who were able to look at the data. And there were methodological flaws that could have been addressed if only there were other pairs of eyes who were trying to analyze the data. Data is being collected as we're speaking, and they are just sitting in the servers. And we think that that is wasted opportunity. We know that we have to wait for the randomized controlled trials to be completed, but that could take a while. In the meantime, we are basing our practice on anecdotal evidence, small case series, but we can do better. There's so much data that is being collected that are available in digital format. And I know that it's not as simple as that. Definitely, we have to respect patient privacy, that there has to be, we have to do due diligence in making sure that patients are de-identified, but we have a track record of doing that. We have been making available data coming from patients from our hospital to the wider research community, and we are happy to share the processes, the algorithms on how to do this safely. But I think this is a perfect opportunity really to showcase the value of learning collaboratively, learning together, learning with different perspectives, and getting that data into the hands of as many brilliant investigators as possible. That is really our advantage over the virus. The virus cannot do this, but we can do this.
Is there any other treatments that you're looking as an ICU doctor? There's been a lot of things talked about remdesivir, convalescent serum, and maybe also the use of blood thinning products, because this disease seems to be very good at creating clots. Can you talk about any of your thoughts on those things?
So blood thinning or anticoagulation has become standard of care. I must say that the evidence to support that is thin. There has not been, I have not seen a randomized controlled trial comparing blood thinners versus no blood thinners. I think we have at this point stopped using hydroxychloroquine. The randomized controlled trials that have been published so far all did not show any benefit. And there are definitely case reports of cardiac complications from the use of hydroxychloroquine. We should hear about randomized controlled trials using remdesivir and then IL-6 inhibitors. Some of the observational studies look promising, but again, observational studies can be confounded. But I think we will have some answers. But even as we wait for these answers, I just wanted to emphasize again that these findings have limitation. So their generalizability should always be questioned outside of the original place where the study was conducted. And also, it's very possible that a medication is effective now, but in a few weeks, in a few months, the virus could mutate. So we have to keep questioning. We have to constantly be evaluating the data, because it's very possible that the findings would have what we call an expiration date. And this is something that we have been promoting all along, that there has to be continuous learning from the data. There is no such thing as ground truth in medicine. Ground truth continuously shifts in healthcare. But let's wait for the results of the studies, but at the same time, let us not stop repeatedly evaluating these treatments of whether they continue to be effective even after a trial has been published.
You know, have you, I don't know, this may be too early, but have we seen any complications sort of long-term from COVID-19? So people, you know, some of the patients are in the ICU for quite a long time. Is there any things like lung fibrosis, issues with kidney problems long-term, neurological? Is there any kind of mental health problems that we need to think about? I don't know if you've experienced or have any thoughts on that.
So before the pandemic, we are aware of what we call the post-ICU syndrome. And these are patients who spend a relatively longer time in the intensive care unit. But we do know that these patients are at very high risk of complications down the road. And this would include cognitive deficits. So they say that up to about 30% of them would have cognitive deficits similar to a traumatic brain injury, and up to 25% of them would have cognitive deficits similar to a mild form of Alzheimer's dementia. And these are among survivors of a prolonged course in the intensive care unit. We also know that a significant fraction of them who were working beforehand will be unemployed. So one study showed that up to 50% of them would be unemployed at 2 years, and up to 1/3 of them will never be employed again, at least at their original level of functioning. And we are very worried that that's going to be the case for the survivors of COVID-19. Other long-term sequela would be, we know that up to 1/3 of them would have major depression, and then up to 10% of them would have post-traumatic stress disorders. And we think that it's probably going to be worse for COVID-19. As you've heard, these patients are, for the most part, sedated very heavily. No one was allowed to visit them while they were in the intensive care unit. And those are typically the measures that we adopt so to avoid this post-ICU syndrome. So I think we will be expecting a much more severe post-ICU syndrome after surviving from an ICU hospitalization from COVID-19. We have to make sure that we support them once they're recovered with mental health support, with emotional support, with physiotherapy, because a lot of them will have ICU-acquired weakness, some neuropathy as a result of critical care illness. So these are all going to be major issues so it's not just getting them out, it's not just surviving an ICU stay, but they have a long road ahead of them of recovery. And a lot of these patients will be going in and out of the hospital. We've seen that as part of the post-ICU syndrome.
I think those are excellent points, really making sure that we follow on up with people. In terms of the vaccine, have you been reading up on anything with the vaccine and any difficulties with making the vaccine, and maybe even thinking about how we would deliver the vaccine in America?
So trials are underway. I mean, all we can do is really hope for the best. But the experts are trying to develop the vaccine as fast as they can, hoping to complete the trials, making sure they're safe, and then of course making sure that they're effective as well. And then we need to know how long they're going to be effective for. Do we need a booster dose or not? So these are the type of questions that are being answered by the ongoing trials.
And We talked about sort of the long-term effect with patients. I mean, how about healthcare workers? I mean, can you just describe about what you're seeing, and you're a very experienced physician. I mean, maybe do you have anything to compare this to? Maybe the end of the when the AIDS epidemic was happening, and what sort of things are going through your mind?
There is some silver lining to this pandemic. I've never seen us healthcare workers really pulling in for each other. Um, I've never seen this in my entire career of each other supporting um, emotionally, physically. We have a a very active group on the phone app where we ask each other's questions all the time, even in the middle of the night. And you see that as well with the nurses. There's definitely some genuine concern for each other during this time. We're getting a lot of support from the community. We are getting fed 24/7. I've never seen so much food in the hospital. But I still think that this will be a traumatic experience for us, not just the healthcare workers, but for everyone. Like if you see people's Facebook feeds, it will be very rare, for example, for not knowing anyone who lost someone to COVID-19. So it maybe this doesn't compare to what happened during the war, but I would say that in terms of the sequela with regard to your mental health, um, there will be post-traumatic stress disorder among the healthcare workers um, and among the general population.
I mean, where do you think things are going to go? I mean, do you think we're at the peak at the moment, or do you think this where we need to be careful that this is going to be a long-term thing over 12, 18 months?
So if we are to learn from the pandemic of 1918, so that hit around March of 1918 and then went away, at least in the cold countries during the summertime, and then came back the following fall. The number of deaths during the second wave exceeded the number of deaths during the first wave. So as you had pointed out earlier on, this is no time to be complacent. We have to be assuming that this will not go away. We have to prepare for a much worse second wave. But we do have some advantages compared to back in 1918. We have information and communication technology. We have really good public health infrastructure now compared to 1918. So we're hoping that the the number of deaths will not be similar to what we saw way back in 1918.
Yeah, I think you make good points, because I think there was 3 waves in 1918 with and every time that they went to go again, there was the issues. So and that's interesting. I mean, do you see the coronavirus will become a seasonal virus like the flu?
We don't know. That will really depend on, one, do we get a vaccine, or two, it could be because of nature that it disappears, like SARS disappeared. We don't know what happened to SARS. We never got a vaccine. But clearly the coronavirus right now is behaving very differently from SARS a decade ago. So once again, there are more questions than answers at this point. And the only way to know is to learn from the data. That's the only amulet that we have.
Are patients behaving similar to like a very severe influenza, or is it quite different?
I mean, the death rate is definitely higher. So this is not typical of influenza. We're seeing more deaths. And at the same time, I don't recall seeing this many young patients presenting to the ICU from influenza. So this from the way it's behaving, it's definitely more virulent than the flu that we see every winter.
Okay, very good. And what sort of questions are you looking at in terms of going forward? Like what is your group particularly interested in?
We are trying to predict outcomes based on their presentation during the first day. If you could predict how long they will be on a mechanical ventilator, then that could help hospitals in terms of resource planning. So those are a few questions that we're trying to address. On a macro level, we also have a team looking at the spread of the virus in the community. There are data sets that are available now that would give you aggregate numbers of new cases and then excess deaths from COVID-19 at the county level, and you could integrate that with other county level information. So census data would tell you the size of the households in that county. It would tell you the race distribution. It would tell you the annual income. So there's so many data out there that if you start integrating them, you get a clearer picture of how the virus behaves in the community. And I just wanted to plug that we have an upcoming COVID-19 datathon that we're organizing at MIT on May 11 to 15. So stay tuned for more announcements about that event. Okay,
that's great. I just want to be respectful with your time. I mean, do you have any sort of final thoughts? I mean, I think people listening, a lot of people probably anxious and just worried about what's happening. I mean, is there any sort of silver lining you mentioned before about where we're going, or just general comments about things for people in America or overseas in New Zealand and elsewhere?
I mean, I just wanted to repeat my message that this is a perfect opportunity to really take advantage of collaborative learning. We need to learn together. We need to bring together various expertise and look at as much data as we can so that we will be prepared for the second wave, for the third wave. If we don't do that, then the virus has an upper hand because of its ability to mutate. But we could get that upper hand by really learning more about how the virus spreads and how the virus kills. So once again, I'm plugging data sharing and collaborative learning are the best medicine to really curb this pandemic.
And you've said a lot of interesting things. Where can people find more information about the work you're doing? Do you have any social media or websites or information that people could learn more?
So we post it under MIT Critical Data. We have several publications coming out hopefully in the next few weeks. And we also would announce events like datathons under that particular label. And we're always open to working with other groups. We would like to promote our approach, and we would like to scale this and replicate what we're doing here in Boston and Cambridge to other parts of the world.
Sounds great. So Leo, thanks very much for your time. I know you're very busy, so we really appreciate everything you're doing and all your colleagues in Boston, and wish you all the very best, and be safe in this period.
Thanks, Xaviour. Take care.
Thank you.